All right, so I'd like to give you what's not exactly an opinion piece, but it's got a fair amount of Walt's medical opinion in on it. So again, this is, yes, my medical opinion. I would like to think it's fairly learned, and whenever possible, it is evidence-based, and it fits with national guidelines. But what I'm going to say may actually kind of shake the world of a lot of people out there, and that is when somebody comes in from EMS and they're given a report, oh, blood pressure severely elevated, 170 over 105. And, you know, I think to myself, if you ask me when do I care about hypertension, that you told me that, I don't. Most of the time, I mean, seriously, it almost never makes a difference to me. There's a few times, but in terms of when I actually care that the person is hypertensive, it is literally almost never, like actually literally. There's a very few specific cases, and then it means a whole lot to me. But the number itself means almost nothing. The actual incidence of a hypertensive emergency is like 1 to 2 cases out of 1 million people per year. And it's certainly not the number of people that come to the emergency department, and they certainly are not truly asymptomatic. Let's talk about this a little bit. Your blood pressure itself, what is your blood pressure? It is the pressure that your vasculature sees when your heart contracts and you force blood through your body. It goes something like this. Again, you have a systolic blood pressure, the top number, a diastolic blood pressure, the bottom number. The systolic number is the force that your heart produces, the most force, the push from it. That's not actually the blood pressure your organs typically see, interestingly enough. That is the force that blood is ejected into your arteries, and then your arteries actually go and they swell up, but they're really springy, generally speaking, and so then they squeeze back down, and eventually they squeeze back down to a point called your diastolic blood pressure, where that is the pressure of blood when the arteries have essentially injected what it is they're going to inject, and before you start another systolic beat. And then there's the mean arterial pressure. And this is the thing that actually gets measured when you're using anything other than a manual blood pressure. When manual blood pressure, you know, we listen, we hear the Krakow things, we go, and we hear that. That's not what an electronic blood pressure cuff sees. What it is looking at is it finds your mean pressure, your mean arterial pressure, then it does a calculation and it gives you your diastolic blood pressure and your systolic blood pressure. But it's not actually measuring your systolic and diastolic blood pressure. It is measuring your map, and then it figures things out from there. And that mean arterial pressure, that's the pressure your organs actually kind of see for perfusion. So that's why a lot of times, yes, we can use systolic and diastolic and that kind of stuff, and they sort of mean different things, and what you do may make a difference with it. But a lot of times when we're talking about the emergency treatment of somebody, their mean arterial pressure, the pressure their organs actually see, that's what we kind of care about. And that number is at about 65. If you can keep that number at about 65, then their organs get blood flow. And below that, maybe they don't quite so much. And above that, well, they do okay for a while. We'll talk more about that in a second. There's all kinds of stuff that goes into how your body regulates blood pressure. Everything from the anatomy of your vasculature to how tight and how much hormonal factor you have running around in it, to tissue factors, to what your kidneys are doing and your adrenal glands and how much blood volume you have, and all that goes into determining your blood pressure. So it's not just how hard your heart squeezes. There's a whole bunch of things that actually make a big difference in terms of what your blood pressure is. So how do you actually take a blood pressure itself, which is a great first place to start. Now, most of the time, what do? We have the person sit down and you immediately throw a cuff on their arm and you're like, okay, here we go, push the button and there it takes. That's not probably a normal blood pressure, or not at least an official blood pressure as we kind of know it. How do you actually take a blood pressure? Well, a person should be sitting quietly for 10 to 15 minutes. And this is why when you bring them into the emergency department and somebody's like, oh man, that first blood pressure is really high. I'm like, yeah, give it 15 minutes. 15 minutes when you're not poking them for IVs or taking them for tests or stuff like that. Give it 15 minutes and you see what the person's actual blood pressure is after they've been sitting calmly. And that's even sitting, not talking. They should have their arm level with their heart. If my heart is here, then my arm needs to be, the cuff needs to be level with that. If they are leaning back, don't have their arm dangling on the side of the bed. You're really supposed to support it at the same level as their heart. And of course, nobody knows that. So you get all kinds of wacky stuff. You'll see people taking a blood pressure when their arm's like that. You have to have an appropriately sized cuff. The patient ideally should be sitting with feet on the floor, which never happens on a stretcher. And then again, you tell the patient, stop talking. don't talk while we're doing this because it does actually change the blood pressure that is measured by the cuff itself. It doesn't necessarily change how much pressure your organs are feeling, but it changes the number that you get. So those are things. Sit quietly with your arms supported with an appropriate sized blood pressure cuff with your feet on the floor and shut up for a minute and let me take your blood pressure. It's almost always going to be higher in the ambulance than it is at the hospital. I almost guarantee it. Now, not all the time. Sometimes, it looks a little different. But why? Well, because we don't take very good blood pressures, and myself included, partly because of logistical issues and partly because it's just not real feasible when you got to get a blood pressure every 5 minutes to have the person sit for 15 minutes and see what happens. But that's why you may notice frequently, when we got there, their blood pressure was meh, and now it's meh, and that it's gone down quite a bit. It's almost always going to be higher in the ambulance. That's not to say you don't need to take a first blood pressure, just that it's probably going to be higher to start with. I do care about it if they're hypotensive, of course. Again, I'm not saying don't take a blood pressure. I'm just saying if it's high, it's probably going to come down in a couple minutes, almost all the time. No, not always. We'll watch for that. Let's talk real quick about some medicines that we use for blood pressure. There are a number of them here. These are kind of the 4 that we use from an emergency kind of standpoint. And again, you may see other blood pressure medicines out there, but let's hit each of these just so you know, because you might actually be asked to give one of these either in the field, coming to the hospital or on transfer or in an aircraft or something like that. So these are the common ones for blood pressure itself. Labetalol is kind of one of the classics. It's a beta blocker. The nice thing about this, and just to give you the high points of it, is we typically think of it lowering blood pressure, but more or less sparing your heart rate. If you give other medicines like, say, metoprolol, they do have an effect on your blood pressure, but they seem to more preferentially affect the heart rate itself, and that's why we may give that for like AFib with RVR, but we tend not to give metoprolol for blood pressure control. So that's an interesting thing to kind of bear in mind. It is a beta blocker, just like any other ones. It's got some alpha activity as well, but we mostly give it if we want to drop blood pressure, but more or less spare heart rate. Nicardipine is another one that you'll commonly see. It's a calcium channel blocker. I like nicardipine. It seems to do, again, a lot for your blood pressure. Sometimes when you give medicines that drop your blood pressure, though, they cause your heart rate to go up, and nicardipine avoids that mostly. Of the calcium channel blockers, you do have some that work on heart rate, some that works on pressure itself, and this tends to work more on blood pressure and not really change your heart rate all that much. It causes some arterial vasodilation, and that's how it does its thing. You'll typically see this given as a infusion or a drip, whereas labetalol you'll typically see kind of given in pushes, either 10 or 20 milligrams, something like that. Nitroglycerin, while we do give it and it does affect your blood pressure, the purpose of nitroglycerin is really not to change blood pressure itself. It's to do other things. So it decreases preload when you give it at sort of lower doses, up to like 300 thereabouts. And it will cause your heart to have to work less hard. And it does. Your blood pressure typically goes down when that happens. But we're not giving it because of the blood pressure. We're not using nitroglycerin to regulate blood pressure. The blood pressure is just kind of there to allow us to give more nitroglycerin, really. And it causes decreased afterload at higher pressure. So actually allows your heart to have less that it has to pump against. This is why it's a great medicine for stuff like heart failure, because it decreases the work on the heart itself, which is already kind of failing and not working very well. And then we'll see hydralazine. Oh, hydralazine. My anecdotal opinion is that medicine services love it, and sometimes it works, but it's inconsistent, and I don't like it all that much. It does increase that sympathetic tone where I mentioned before, like sometimes you drop blood pressure and you cause some arterial dilation, then you actually increase the heart rate at the same time. It has, in my opinion, inconsistent effects. It just is not predictable in who it's going to work for. There is at least a suspicion that hydralazine works really well the more hypertensive you are. And if you're just a little bit hypertensive, then it doesn't really do a whole lot. But maybe if you're like truly hypertensive, like hypertension, 220 over some odd, and you cause some arterial vasodilation, that it works better in that case. Again, I have seen it given a number of times, typically by either a medicine service or by an OB service. I am not convinced that it actually does much of anything for most people, and it's very hard to use. And again, you fight me on it if you want, but that's been my experience with it. So I tend not to recommend or use a lot of hydralazine, and I think most of the EM guys would agree with me on that. Let's get into the meat of times that I actually care about hypertension outside of almost never, because there are a few times. There are some times when, yes, we really have to pay attention to it, but that's not most of the time. Okay, one time I care about hypertension is when it makes another problem worse. And that is to say that the number itself doesn't bother me, but the fact that there is a lot of pressure pushing on something, that is the problem itself. And then, yes, I care about hypertension quite a bit in the setting of intracranial hemorrhage, dissection, or an aortic emergency, and in pregnancy, because they make other things worse. Now, intracranial hemorrhage, there's a lot of different flavors of, and I honestly don't care that blood pressure is high in most of these because, well, I shouldn't say most of these, in some of these. After trauma, really not that kind of big a deal for a higher blood pressure. And in fact, sometimes a higher number is a bit more desired because a lower blood pressure means less perfusion. Well, the times when we really care about it is, again, when it makes something worse, like when you've had an aneurysmal bleed. So if you have a little outpouching of thin-walled ballooning artery here, and then that ruptures, you spill blood into the subarachnoid space and you compress the tissues and you decrease blood flow to the area beyond it, typically speaking, and that's a problem. And the higher the pressure is that you squirt blood out, theoretically, the less space you have in your head, and I guess it's not really theoretically, it just makes sense. When you squirt that blood up into a higher pressure space and you bleed more, you take up more space and more pressure that you needed for brain tissue and squish it down and compress it, and squished brain doesn't work very well. And so we want to control these people's blood pressure pretty tightly, especially in the setting of aneurysmal bleeding or in those interparenchymal hemorrhages that I showed you there itself. If you put lower pressure on those blood vessels, hopefully you can control bleeding and control the amount of blood that gets dumped into the head itself better. Again, in trauma, we don't really care about it. What we are worried about then is that you've got blood leaking into your head, either from a torn vein or from a torn epidural artery over there. And then you want to keep the blood pressure up, and you don't want to regulate it. You don't want to get it down to 140, whereas in the setting of those aneurysmal bleeds or interparenchymal bleeds that happen seemingly as a result of longstanding hypertension, then we want to get the pressure down so that you bleed less. After trauma, you typically let their blood pressure go on the high side and let your body kind of self-regulate. So tight blood pressure control in trauma is not the thing. Don't reach for the labetalol when you know somebody's got a head injury all the time or an intracranial hemorrhage all the time anyway. All right, you could mention what do we care about blood pressure in stroke? Because we'll talk a lot about blood pressure in stroke. The big reason that we mostly care about it when we first start, and why you may see folks saying we should do blood pressure control in the field for a suspected stroke, is because in order to safely give them thrombolytics, typically speaking, you want their blood pressure decently controlled, and that number is 185 over 110 in order to safely give them a dose of tenecteplase, TNK. And the problem is that if the blood pressure is high, you increase the chance that they go from an ischemic stroke here to bleeding through those damaged, injured little blood vessels and bits of brain after that. So you don't want the pressure to go high in the setting of ischemic stroke if you're going to give them medicine for it. And so you might ask, shouldn't we just give all these people that have suspected strokes blood pressure medicine in the field and just go ahead and get them down to 180? The problem is that if you don't give them thrombolytics, then we tend to actually just let the blood pressure ride because they have, again, increased intracranial pressure often, and we want their brain to get as much blood flow as you can. And so having maybe a higher blood pressure can be your body essentially trying to regulate itself and trying to force blood past the little clot, the little bit of whatever it is that is blocking off that section of brain from getting blood flow. And so you want a higher pressure there to keep as much as you can kind of forcing up in there. So we let that blood pressure ride up to around 220, typically thereabouts. Now, above 220 over, say, 120, everybody's going to get some blood pressure control because there's not benefit to that. And every recommendation that's out there is going to say, give this person blood pressure control. So now, that's not necessarily everybody, and there's a lot to that, so it's worth a conversation with medical control if that's something you're thinking about. But it's not unreasonable. Outside of that one very specific case, If their blood pressure is elevated, we typically are going to let that ride until we're sure that they're a thrombolytic candidate, and that's what we want to do, or are pretty sure that they might be at least. And then we're probably going to let their blood pressure kind of continue on. But also the other consideration, as I kind of mentioned before, is that your first blood pressure that you get in the ambulance, after the person sits for a minute and again kind of everything chills out, their blood pressure is probably going to go down, generally speaking. And again, I'm not making the case to not do anything in the field because things will change. I'm just saying in this case, that number may be kind of falsely elevated, and probably is falsely elevated a bit. And so if their true blood pressure is going to settle around 180 or so, and you gave them a whole bunch of medicine to get them down to it, and then they settle out anyway, and now their blood pressure is 120 when it was 200, well, now their brain's not seeing near the blood flow that it probably wanted before, and you can make things worse by doing that. So long story short, shouldn't we drop all the stroke blood pressures in the field? No. There is a select group, again, greater than 220 over 120 that the ED is going to treat regardless, or should treat regardless, because that's in every recommendation that's actually out there. But that's worth a call to medical control before you just take it upon yourself to do it. The other time when I really care about blood pressure control is, again, when it makes things worse. That's in the case of aortic emergencies, either dissection or an aneurysm. So if you don't know exactly what an aortic dissection is, this is a nice little animation, and I don't know who Cal Shipley is, but he did a good job. So you'll get a little tear on the lining, the innermost lining of the aorta itself, which lets blood get in kind of behind it, which you'll see here in just a second. Then the dissection part is when it pulls away that interior lining from the rest of the aorta. And that moves along here, and you'll see that kind of happen as it propagates up and sort of, again, pulls off the inside lining of it. Now that can be a problem because blood doesn't actually flow through that section. It just kind of sits there, and it can compress stuff, and if it dissects out into one of the other arteries, then it can completely block off the artery actually, because it's just taking up space and blood can't flow through it. It's just going into that extra spot. But it also, if it goes far enough down, will eventually reach the pericardium, and it can dissect out and give you tamponade after that. Dissection's a bad thing, and it's kind of hard to pick up. These can cause all kinds of things when they occur. The things when I kind of worry about it, especially why you might clinically suspect this, is somebody who has chest pain plus something else. It could be back pain, although back pain's pretty commonly with it, but chest pain plus belly pain, I got to worry about that because that's the territory of the aorta. Chest pain plus severe pain in my feet that came on at the same time. You dissect up here and it blocks off blood flow farther down as that propagates, and then you don't have blood flow to your feet and you have two ischemic legs. Or somebody that suddenly has chest pain and a stroke, or chest pain plus leg weakness, or asymmetric pulses. Those are all things we worry about. But it's really hard to pick up dissections without something else. My, again, kind of classic tip is if they have chest pain plus something else, or chest pain plus a neurodeficit, that's somebody that I'm really worried about dissection, or chest pain plus pain in another area. There's also aortic aneurysms, and these are little outpouchings that occur, or weakenings in the wall of the aorta itself. Typically, we think of these, they can happen in the chest, but they often happen in the belly as well. And these things are, asymptomatic essentially. Sometimes you can form little clots along the side of these. But the big problem is that eventually they get so thin-walled that they rupture. And then you leak blood from that hole at arterial pressure into an uncompressible space, i.e. your abdomen, and you end up with your blood volume in your abdomen, and that's bad. Sometimes they will manage what type it is medically, meaning good blood pressure control and that kind of stuff. But if it's in the top part of the aorta, typically speaking, or if it's really big or causing bad symptoms otherwise, a lot of times what you can do is either take that section out, or they can put in a graft. They can put in a tube on the inside so that you don't have to go from the outside and get your aorta cut. You can bypass that section and give the blood someplace else to go. And you can do that. Like, what do we actually care about it for, though? I said there are very few times, and I've lost the thread of actually talking about blood pressure here for a second. Why do we care about blood pressure? Well, we want it to be really low, basically as low as you can get it, because every time your heart squeezes, every bit of pressure that either comes out of your ruptured aneurysm or dissected aorta is more stress that is putting on the area and makes things potentially worse. So we want to have pretty darn good blood pressure control. And in that case, that's, again, pretty much as low as you can get their blood pressure and have the guy still conscious is sort of what you actually want. But certainly under 120 often, with a heart rate under 60 to minimize the number of times that your heart squeezes against that thing as well. The thing is that in cases of, aneurysmal subarachnoid bleeding or ischemic stroke or thoracic aortic dissection or aortic aneurysm rupture, these people aren't going to call about their blood pressure. They're not going to call because their blood pressure's high. They're going to call about their chest pain or their stroke or their, severe headache or their inability to do anything without moving around and vomiting. They're not going to call about their blood pressure. Additionally, don't worry about the blood pressure so much. For us, let's treat the stroke, or we treat the chest pain if it's something that's out there. Don't lose sight of the fact that you're still mostly worried about, is this a stroke, and working up the chest pain and that sort of stuff. All right, the other time when I really care about hypertension is when it's so bad that it impairs your body from working. This is the true hypertensive emergency, not this, the stroke or something like that. This is the true time when it's blood pressure itself that causes end organ damage. When is the blood pressure so high that it's actually hurting your own organs, your brain, your kidneys, your heart, etc.? There's this thing called autoregulation, which works pretty well and keeps us alive. Your body is able to regulate blood flow through different organs at a really pretty substantial amount over a wide range of pressures. Otherwise, as soon as your blood pressure dropped because you got a little bit dehydrated, we would die. Now, when you get like super low, yes, then the body loses the ability to do it. Likewise, when you get super high, the pressure just kind of forces itself through and your brain, your body, your vasculature can't protect your brain or your kidneys from it. So you get things like edema that happen with it, or same thing if it goes through your lungs, you get pulmonary edema. But over a relatively wide range, your body has a pretty good ability to auto-regulate each individual organ and blood flow to each individual organ that gives you consistent blood flow. So it's really a question of, did you damage the end organ itself? So the end organ itself can be affected in lots of different ways. So from a cardiovascular side, this can cause some chest pain, or you can have EKG changes that go with it. You can have shortness of breath, either with or without pulmonary edema, depending on where things are actually going wrong at. But this looks like, what would you call that? Well, maybe ACS, maybe it's a dissection, maybe it looks like CHF. But sometimes that can be due to your blood pressure, but you got to work up the rest of it first. You got to function on those much more common things, because again, true hypertensive emergencies are like 1 in a million. You can have hypertensive emergency of the eye, which is called retinopathy. Usually this doesn't cause visual changes. So we'll see lots of people that come in and say, I feel like my vision's blurry. Like, well, and I took my blood pressure and it was high. Well, typically they don't have blurry vision, and oftentimes they don't even notice it until this has progressed for a long time, because it's stuff that happens at the back of the eye itself. Typically speaking, you don't see these little white spots as they cross over arteries or veins. I think these are actually arteries that are blocking off veins, or little hemorrhages or stuff like that. Typically the eye doctor looks in and says, oh God, and then you get the diagnosis of hypertensive retinopathy. Typically speaking, they don't necessarily come in with an acute visual change, and if it is a true acute visual change, then you might think like a stroke or something to be more common. I suppose it's maybe possible, but true hypertensive emergency of the eye is not very common, at least from an acute setting, and not a diagnosis that we often make. How about hypertensive encephalopathy? Everybody says, I came in because I was worried because my blood pressure is high and I have a headache. Well, yeah, you can get a hypertensive emergency that's related to headache, but almost certainly it's not. It's possible. It definitely is. I'm not going to say that nobody that comes in with a headache is having a hypertensive emergency, but typically speaking, your blood pressure goes up because you have the headache, rather than you get a headache because your blood pressure is actually up. And you will never convince people of that, so don't even try. But true hypertensive encephalopathy tends to be insidious. You can get headaches that are associated with high blood pressure because you have intracranial hemorrhage. but the hypertensive emergency itself that causes encephalopathy, this happens over the course of usually a couple of days, and they have non-focal neurologic symptoms. Again, encephalopathic, they're just not following. Maybe they are getting a unilateral deficit. Maybe they have nausea, vomiting, but this is not typically something that happens over the course of like 5 minutes or sudden onset. There are other things that are associated with high blood pressure, but the brain damage from hypertension itself usually is more of an insidious onset. Similar to your kidneys typically don't just like explode and stop working when your blood pressure was high for one day. So folks will watch this often, and the hypertensive emergency as it relates to your kidneys tends to be a progressive decline in your renal function. You can get some microscopic hematuria. It's usually not I'm peeing blood because I'm bleeding into my ureter or something like that, but you see decreased kidney function and maybe some hematuria that goes with it from that high pressure. But again, this is usually not something that happened today, and it's not something the patient's going to be like complaining about. Oh my gosh, my kidneys hurt and my blood pressure's up. Typically speaking, that's not really what you're going to see from that hypertensive emergency. The take-home message is that most of these things that people are going to call about and they say, oh, it's my blood pressure, they're not actual hypertensive emergencies. And I basically just ignore the number of their blood pressure and just kind of try to figure out what's making the person call in. And if it is truly they are just worried about the blood pressure, but they are asymptomatic, there's really nothing much to do with it. Now, whatever their complaint is, their loss of vision, their weakness on one side, their constant fatigue that is due to their new creatinine of 10 and their GFR of 10, and here comes dialysis. Those are hypertensive emergencies, and those are the things that we got to watch out for. But most of the stuff when somebody has the wherewithal to say, my blood pressure's up and it's causing well, it's probably not the blood pressure that's causing it. Something else is going on, and they may have hypertension at the same time. Let's chat about a couple of things real quick that are typically thought of, again, as related to blood pressure, but are probably not actually due to the blood pressure itself. Sudden onset confusion. You can get that, well, it's probably either the drugs or maybe the withdrawal, or maybe it's the stroke, or maybe it's something else or medication side effect. But sudden onset confusion, again, normal now, abnormal a minute later, there's probably some secondary hypertension to it, but it's probably not truly from the blood pressure number. There could be other things, but sudden onset confusion is typically not a hypertensive emergency or hypertensive encephalopathy. That's an indolent process that takes several days. Headache, as I mentioned before, could be associated with a hypertensive emergency, but typically speaking is almost certainly not. Broadly speaking, could be. Can't say it's not, but it probably doesn't actually have anything to do with your blood pressure itself. Blurry vision, again, is usually not associated with, just like an indistinctness in vision. Now, true loss of vision, like, my eye stopped working, I can't see anything out of it. Bigger deal, not saying it's not an emergency, probably not due to the blood pressure, though. Someone who suddenly can't walk, talk, or move again may be an emergency, absolutely, should be worked up for a stroke, and you should probably take really good care of them, but there's a good chance that it is not actually the blood pressure that's the problem. The one time when I can absolutely tell you that like the blood pressure is not a problem is somebody who comes in with a little bit of subconjunctival hemorrhage. I can't tell you how many people I've seen that rub their eye, they get a little bit of bleeding across the sclera. There is no problem here. This will go away. You just tore a little blood vessel. The blood doesn't have any place else to go. It's very dramatic. And then the person gets freaked out about it. They take their blood pressure. It's a little high. They take their blood pressure again because now they're more freaked out because their blood pressure is a little high and they're bleeding in their eye. And now it's a lot higher. And now it's a lot higher when you check it again. And oh my God, and then they call 911. And you've all seen this happen. It actually is just a little bit of blood in the across the sclera of the eye itself. And it's not a big deal. And it doesn't have anything to do with your blood pressure itself, almost certainly. Again, can never really prove a negative, but I'm going to say, this is probably not related to your blood pressure. Another time when I care about hypertension, again, other than kind of almost never. And again, I'm not saying that nobody who is hypertensive is not sick. Just is it the blood pressure that's causing it? Do you need to worry about that number? Probably not. Anyway, a pregnant woman greater than 16 weeks, and I mentioned this earlier in the beginning when I said it's something that gets worse with hypertension, and then I worry about the number itself. When it's a pregnant woman greater than 16 weeks and they are hypertensive, then we start to worry a lot. Why? Because they could become preeclamptic, or this could be a sign of preeclampsia. The thing that we worry about in a woman in her second trimester of pregnancy is preeclampsia, and it could be second or third trimester. Typically, this is described as somebody that's greater than 20 weeks, but they have an elevated blood pressure and some other symptoms. What actually is going on in preeclampsia? We know that the placenta has something to do with it, and what it appears to be is that the placenta itself causes vasoconstriction, or your body's reaction to the placenta through some neurohormonal factors causes some vasoconstriction in different parts of the body. So that could be a number of different places. It could be in the brain, it could be in the eyes, or around the gut. It typically is associated with relatively sudden weight gain, different from like pregnancy weight itself, but all of a sudden, oh man, I gained 5 pounds over the weekend, or 10 pounds over the weekend, and you get all puffy, especially if you start to get it in your hands and your face, then we worry about it a bit more. And again, it's associated with an elevated blood pressure from that vasoconstriction. I'm probably describing this a bit wrong, but it'll get us close enough for what it is that we need to be able to do. Problem is that when you vasoconstrict blood flow in organs inappropriately, then they don't get the blood flow that they need, and they cause symptoms. So there are a lot of sort of vague symptoms that can occur with the preeclampsia itself that the person wouldn't necessarily seek care for, and then you find it, during a 911 call for something else. There's preeclampsia itself, which is the hypertension plus like these symptoms essentially. There's severe preeclampsia where you actually start to cause like liver trouble and you start chewing up red blood cells, and you have low platelets, and you start to get little clots everywhere. And then there's eclampsia itself. The difference between eclampsia and preeclampsia is basically when you have a seizure as a result of this stuff, then you have eclampsia. Now this is different than somebody whose blood pressure was always hypertension before pregnancy and just remains hypertensive. And this is different. Eclampsia is different than somebody who has a seizure disorder and then has a seizure while they're pregnant. In the Southwest Ohio protocols, we do actually have a recommendation for seizure treatment in pregnancy, which is midazolam. For someone with eclampsia, to start magnesium sulfate, which is a vasodilator, which is the idea that will help return blood flow to normal. These people end up on magnesium. But the blood pressure part of it itself, the threshold for initiating antihypertensive therapy is 160 over 110 in this particular case. And again, you have to do 2 occasions, 15 minutes apart. Let's be honest, if they are with you in the ambulance for long enough for you to say, I'm going to start antihypertensive therapy on this person because I've had 2 good blood pressures that are all 15 minutes apart, I kind of wonder what we were doing in the meantime and why we aren't at the hospital itself. None of us want to sit out in the field with a seizing, severely hypertensive second or third trimester pregnant woman. Everybody can agree to that. But it is in there if you were to initiate antihypertensive medicines. The other time when I care about hypertension, again, almost never, but when else might I care about it? Well, when it's a sign of something else. So there's these things called, for instance, pheochromocytomas. These are little tumors that sit on your adrenal glands and cause you to release all your epinephrine. Essentially, you get a fight or flight response for no good reason, sometimes after trauma or stuff like that. But these little tumors release all your epinephrine. And so your blood pressure goes super high and your heart rate goes super high. And you look like you're on some sort of stimulant. But actually, it's because you have this little tumor. And these are really hard to find, and they're really pretty rare. And if you look at everybody, eventually you find one. But again, it's almost never found, at least on the emergency kind of standpoint. I also worry about it when it's from increased ICP, although I don't actually do anything about it. So if somebody gets a bad blow to the head, and then I notice that their GCS is essentially comatose, they're starting to posture, and their systolic blood pressure is high, BP is 200 over some odd, their heart rate is in the 40s, and they have this kind of ataxic respiration. This is Cushing's triad. This is increased ICP. This is the stuff that happens with it. While I do worry that the person is now hypertensive from their terrible head injury, like it's that bad, the treatment is not to treat the blood pressure. The treatment is to fix whatever is causing the increased intracranial pressure. So again, I do worry about it, but it's not the blood pressure that's truly the problem. Same thing with your thyroid. While it can lead to severe hypertension, the problem itself is, yes, you do control their terrible like sympathetic storm that kind of happens with it from their thyroid type stuff. But the big thing is let's fix the thyroid. It's not so much the number. The number is just the symptom of it. And yes, we want to be aware of it. I'm again never saying that bad things don't happen when you have a severely elevated blood pressure. I do say that it's rarely the number that makes a big difference. And typically just hypertension itself, you really don't notice any of that stuff on this, kind of infographic here. But people typically, in this case, will have something else kind of going on. Same thing with withdrawal. Folks will get hypertensive, especially if they are coming off of a benzo or something that would have depressed your CNS ahead of time. Alcohol, for instance, your blood pressure does go up with it. That's one kind of objective thing that you often see just from a lack of, a foot on the brake essentially all the time. And so you can see it with withdrawal. You can see it with alcohol withdrawal, with benzo withdrawal, with clonidine withdrawal especially. Clonidine typically will kind of suppress things from a adrenergic standpoint. And then when you stop taking it, all of a sudden, all that stuff roars back up. And so it's certainly something that happens out there. We'll also see it, severely hypertensive as a result of drugs. And you can't see it behind my head here, but some of these are relatively easy to get a hold of. You can think of cocaine or meth. This little guy, this little spiky ball, this is called Jimson weed, and it's something that teenagers will get a hold of, and they'll eat parts of the plant, eat this, I think it's the seeds. And then you get this essentially anticholinergic crisis that happens with it. And your blood pressure goes up real high. And again, is the problem the number of the blood pressure? Probably not so much. The inciting factor is, in fact, the meth or something like that. And so, yes, we worry about the blood pressure being up, but it is not our primary concern. It's when it happens as a result of something else. Likewise, serotonin syndrome, when you're on a bunch of serotonergic agents, and typically you get confused and hypertensive and get this autonomic instability that goes along with it as well as another thing, the kind of co-traveler called neuroleptic malignant syndrome. And yes, these are concerning things and they're associated with hypertension. But you notice out of all these things that I just showed you here, all the times when we might be concerned about it, honestly, they're not going to call 911 because their blood pressure's up. There's going to be something else that's happening. And that's the real thing. It is not the asymptomatic hypertension that we have to worry about. These people won't tell you their blood pressure's up because, well, they probably couldn't make it to the blood pressure cuff or get it on to start with. It is going to be something else that you see, and that's what you should be concerned about. Yes, people with hypertension can be exceedingly sick, and sometimes your blood pressure goes up as a result of it, but it's a symptom and not the cause itself. So to sum up, evaluate the symptoms rather than the number of the blood pressure itself. High blood pressure is almost always in the setting of most people that come to the ED, as long as it's isolated, I'm just worried about my blood pressure, they will almost always get better with time and resist the urge to make big moves because you can hurt somebody. An acute symptom that the patient knows about is probably not related to their blood pressure itself. Certainly hypertension over a long period of time that's untreated can certainly cause you problems, but it is rarely noted as an acute symptom unless something else is happening as a result of it. And high blood pressure accompanies a whole bunch of dangerous things, but rarely causes it. So that is, again, my look at hypertension. And I don't want anybody to think that I am saying, don't check vital signs or that I don't care. I just don't care about the hypertension number itself. Typically speaking, what I'm really more concerned about is what is going on behind it otherwise. The number, I can make the number do anything I want. The thing is, I need to know why I'm doing it. If it's because of their head, if it's because of the drugs they took, if it's because of their aortic aneurysm, or what's going on. So that said, hope this is helpful. We'll see you later.